Oh, there we go. That is when somebody gets more agitated, more anxious, more confused later in the afternoon, in the evening when the sun is going down. People do experience times where they are accusing their loved ones of something that might not be so nice. They can be suspicious or paranoid. We may see pacing, we can see restlessness, or they may try to leave their safe place. And sometimes we see resistance to new environments or routines. So, why does logic and reasoning and correction often backfire? That is because the reasoning portion of the brain is impaired. So, arguing with your loved one who is fixed on a delusion or hallucination, bringing them back to reality or trying to do that is most likely not going to be successful. And when we correct, it a lot of time does increase someone's fear and they become defensive. Logic assumes the brain is still functioning optimally. And we know with dementia, that's not the case. Repetition. A lot of times families get really worn down by hearing the same question every 2 minutes from their loved one. But it's not them being difficult. It's not them being stubborn. There really is a neurological reason that that's happening. They don't remember that they just asked the question and they don't remember the answer. Emotional memory outlasts factual memory. So they're going to hold on to emotional things longer than the facts. So approach to care, I'm going to give you a few tips here, and I'm keeping an eye on the time because I want to make sure that we have time for Q&A at the end. But when you're supporting a loved one who has dementia, we always want to approach them from the front. And that's because earlier we learned about the visual perceptual changes that are occurring. And if somebody does not have peripheral vision, if you approach them from the side or the back, you're most likely going to startle them, which might have a whole other piece that comes along with that, right? And I see that quite often where staff in a community and they're doing a great job and really caring for these people. And they're, it's a fast paced environment, but they come up from behind and the person screams and is very startled. Discovering the why behind the unmet need. When there is agitation, anxiety, a change in personality or mood, of course, ruling out something medical that's causing that. But the next step is to figure out why. Why is that happening? Because again, this is their communication. Their behavior is their communication. So asking ourselves, are they hungry? Are they cold? Are they tired? Is the environment too noisy? Are they overwhelmed? Are they bored? Are they in pain? All of those things, we have to kind of have a checklist in our mind that we go through to try to figure out what it is that they're trying to communicate to us. Really be mindful of what you say and how you say it. So I always tell people, if you can eliminate one word, it's the word remember. Asking somebody with a cognitive decline to remember something can cause a lot of emotions for them. It can cause them to be sad. It can cause them to be embarrassed. It might even make them mad. So just being mindful of the way that we're wording things, and keeping in mind that they might be having difficulty interpreting what you're saying. So keeping tasks just very one or two prompts at a time, depending on your loved one's abilities, because more than that, a long drawn out sentence or explanation for something can really just be overwhelming. Keep it simple. We want to foster choices and we want to foster independence, but we don't want it to be too much. And when I visit people in their homes, a lot of times I find that their walk-in closet is full of clothing, which is a great thing, but it's making them become stuck in being able to pick out their clothes for the day because it's just too overwhelming. So really just limiting the choices so that they still have a say, but we're making it less overwhelming. So would you like apple juice or orange juice today? Would you like to wear the red sweater or the blue sweater? We want to support overall well-being and sense of purpose. So people with dementia have had a lot of losses, right? Maybe they've lost their job, maybe they've lost the ability to drive, maybe they've lost their independence. And so we want to look at what can we do to foster an environment where we're looking at their overall well-being and we're creating a sense of purpose. And I'm going to just give you one example. I was working with a person who used to be the community baker. Everyone would come to her to bake birthday cakes, and she couldn't remember how the steps and to be able to bake that cake. So we put together a checklist for her, and it's one that she can draw a line through and reuse that so that she's still able to have that independence and be able to do something that she was so passionate about. So it's coming up with creative ways to help your loved one still have that sense of purpose. And routine is so important for anybody who has a cognitive impairment. Routine reduces confusion, it sets expectations, and it helps somebody stay on track. And that's why a lot of times we see somebody who has dementia and they unfortunately have to go to a doctor's appointment, or maybe they're hospitalized, they've had an injury or an illness. Getting out of that routine really increases challenging behaviors. So why one size fits all dementia advice doesn't work? The Alzheimer's Association is wonderful. You can go to their website and get a ton of really great information. And it's general, which is fine. But dementia is not one size fits all. Every single person that I work with is different. The stage of their dementia, their overall health, the environment, where do they live, how is their support system, what are their abilities and capabilities in taking care of them. All of those things are really important when we develop a personalized plan to help that person and their caregivers. So just internet tips lack that clinical context and personalized guidance. When you do get individualized care, it will prevent burnout because there'll be plans in place and effective strategies to support not only the person with dementia, but their care team as well and their family members. So if you've ever thought to yourself, taking care of your loved one, I'm just not sure what to do, I can't do it, maybe you are feeling overwhelmed, or you feel like no matter what I do, it's not working, those things can say that you would benefit from some additional support. And so that type of guidance really can make a difference. Early support prevents crisis-driven decisions where I see people do wait, and then there's a serious event that happens, and now they're facing these difficult decisions on a timeline, and the outcome might not be what they were really hoping for. But this just an objective assessment does bring clarity and direction. These personalized strategies reduce behaviors and stress not only for your loved one, but also for you. And it's not just getting information, right? It's gaining that confidence. So I do offer those one-on-one clinical dementia specialized personalized plans and care strategies. And I just wanted to make a note that I do offer a complimentary 20-minute care consultation. You can self-book that through my website, which I'll share that information with you later, so that you're able to just get a little bit of support there. All right. So I know I ran through that quick because I'm looking at the time and I want to make sure we're good there. Okay. All right. So my part is finished.
Awesome. Thank you so much, Andrea. Okay. I like the fact that you pointed out that dementia is not just about memory. And I think one of the greatest misnomers in our field is the whole thing called the memory care centers, because everybody just thinks it's memory. And dementia, like you said, affects so many different kinds of people and so many different stages. And so it's so important that people understand this. I mean, I've treated people with dementia that have no memory loss at all, nothing. Their memory is completely intact, but they have deficits in cognition, ability to calculate tips, for instance, or navigate home, which have very little to do with memory. My question
Right.
to you is, what would you say is probably your greatest challenge when working with loved ones whose loved, I mean, people whose loved ones have dementia?
That's a great question. I think, what I see often is people they go to their primary care, they go to the neurologist, and they're diagnosed with dementia, and they're usually handed a prescription, and then we'll see you in 6 months. And I feel that people are lost out there navigating this.
Yeah,
People do not know that you exist. People do not know that I exist, and there is a bridge that can really help people navigate through that journey. But, most of the time people contact me when the challenging behaviors are extreme, right? So somebody is trying to leave the home, or maybe they have left the home in the middle of the night and no one's noticed until later. So those types of things can be really challenging for families. And it's a fine balance in being able to care for your loved one, but also being able to care for yourself. So I think
right.
those are the places that I support families most.
Totally understood. Yeah, that's so important. All right. So without spending much time, I'm going to go into to share my screen. Thank you,
Perfect.
Andrea, again for doing that. And then we'll get into mine so we have enough time. By the way, folks, I posted in the chat box that you can send an email either to Andrea or to myself. Wait, I hope I got this right. I did not. Are you seeing my screen? No.
Not yet.
Okay. I always get this wrong. Um,
Down at the bottom, you'll see a share button
I
with a
see it.
green arrow. There you
Yeah,
go.
Zoom has changed a lot of things now. So
I know.
it's not there. You have to find it in a certain spot. Okay, so are you
Yes.
thinking? I said, okay, so I'm going to click on share again. Okay, good. Okay, so folks, if you'd like to do that, if you have any questions, go ahead and just type. If the chat box is still not working, send us an email, and then Andrea can go over them while I'm doing my presentation. Okay.
Perfect.
Okay. So I'm going to go right into it now. Hello, everyone. Again, thank you, Andrea, for inviting me
Hi.
to do this. I'm super excited because, again, it's about looking at dementia from as many angles as possible. I treat dementia, and I also do a lot in terms of education and empowering not just clients but also lay people, but also caregivers, people in the senior care industry, and basically these are the people that are in most touch with seniors and people who are suffering or beginning to suffer from dementia. And I feel that there's a lot of information that for some reason or the other has been kept from the lay public about dementia and what you can do to prevent dementia. And in some cases, yes, it's actually possible to reverse in some cases dementia. And I know this sounds like heresy that I'm saying, but please just bear with me because we're going to explain some things as we go along. Again, if you have any questions, please send us an email and we will get to it for you. All right, if I can get past the first stage. This is a presentation I do all the time. It's called Keeping Your Marbles. And I want to start with this quick story. I'm going to put my stopwatch on, so make sure that I keep to time. We're talking about two individuals, same age. They both are 65. Now, one of them, let's say Mike A. Mike A had a difficult childhood, was in foster homes, was bounced around, suffered some degree of abuse, unfortunately. Um, Eventually was adopted, difficult home. You know how that works. Eventually, he goes into the military because that's what everybody does who can't go to college, right? That's wrong. But he goes to the army. He's deployed on the war front, maybe in Iraq or somewhere. He experiences a lot of gunshot injury. He loses close friends to in the field of battle. He suffers PTSD. He has TBI, concussions. Comes back home and finds out his wife has run up with his best friend. If that hits too close to home, I apologize. He turns to drugs. He's drunk. He develops dementia. Sorry, excuse me. He develops diabetes. He starts drinking recklessly. He finds it difficult to get a job. He's constantly struggling with his finances. Mike B, on the other hand, is born into a loving family. He goes to a nice college, gets a great job, marries his high school sweethearts. They have two or three kids. They have three kids, and and he has no financial problems whatsoever. He contributes, he volunteers in in his community. Everybody loves him. He's doing well. His kids themselves grow to be law-abiding, helpful citizens. Now, when they both turn 65, without knowing anything else about them, their genetics, their history, whatever else, just based on these facts, who would you think, and I'm probably ask you, Andrea, who would you say would be most likely to develop or to be at a higher risk of dementia at the age of 65?
The first one.
Mike A, right?
Right.
Why is that?
Just because of the everything that he's gone through.
Absolutely.
Yeah.
And that's what it comes down to, folks. Dementia is not some alien disease. And we were taught that when I was going through medical school almost 30 years ago. We were taught that it's some kind of alien disease. We've never seen it before. And it's going to come on you. It's like a sniper. It's just going to pick whomever it wants and it's going to strike. And you have no recourse, no help, no hope. All the doctors can do is just manage the symptoms until you die. It is absolutely irreversible. It is inevitable, like Thanos in the Avengers movies. It's going to get you no matter what. And I'm here to say, folks, that that simply is not true. Now, on the left side is a normal brain. On the right side is an Alzheimer's disease-ridden brain of the person who is living with Alzheimer's disease. By the time a person has full-blown out dementia, it's as if he has lost at least 30% of his total brain mass. Again, that doesn't just happen. In most of my patients, when we go through a history and we examine and we look at all their background, their labs and all that, there's usually a sequence of events that led them to this stage. It's almost never just a genetic consequence. By the way, folks, it's about 5%. What they now say is that it's only about 5% of all dementia cases that are purely genetic. So the rest has a lot to do with what happened to these individuals, their loved ones, in the course of the decades that preceded the diagnosis. And I love the Alzheimer's Association definition. It is a brain disease that is caused by complex brain changes. And here's the key: following cell damage. And there's a picture here I want to show that it's kind of like shows the progression. There's cellular damage, complex brain changes, degeneration, symptoms worsen, and then it's a cycle that just continues to repeat itself. So the question that we had, and I've been treating brain disorders for years now. We first started with kids with very young kids with brain disorders, and we kind of evolved or grew to start addressing adults with brain disorders. And we see patterns that most neurologists simply don't see because we started with kids, very, very young kids, 6 months and above. And so we see patterns and we see that that before damage happens, and we kind of stressed a few of them. In Mike A's case, the traumatic brain injury, PTSD, loss of loved ones, loss of his family, financial stress, sleep problems, diabetes, hypertension. There's a myriad of things. So you may say, well, your loved one didn't exhibit any of those symptoms or those signs or that history. There's a huge amount of things that can cause it, and I feel that these need to we need to educate people on all the different things that can lead to dementia. So I came up with a talk called Dementia's Dirty Dozen. We actually have a free ebook where you can see how each of these play into dementia. Interestingly enough, they all started with the letter I. That was not the initial plan, but you may be able to recognize some of these things. Insomnia, what do you think, Andrea? Any of these stand out to you?
Yes, they certainly do. Isolation.
Mm.
I do several talks at communities about the importance of socialization. And I think that's something that most people don't think about.
Especially men.
Yes.
I think. Yeah.
Yes, I think you're right.
So it is never just one thing. It's usually a compounding effect. That's what we've seen. One thing leads to the other. Sometimes they're totally independent, but they all work together to eventually cause the brain to shut down. But I really want to go back to further upstream to really what is the uh, what we call the root of all evil right here. It's not just if it were just brain damage, it would not be dementia. It goes beyond just the brain damage. And this is what it really, really comes down to. It's a loss of energy, specifically brain energy. The brain of the person who eventually has dementia is no longer producing enough energy to maintain its functions. And there's a myriad of functions, but obviously part of them include memory and cognition, navigation, finding one's place in the world. In addition to all the subconscious activities, digestion, breathing, respiration, and so on. So the brain does a lot, and it requires a lot of energy to do so. Once that energy is lost, and all these different things, the dementia's dirty dozen, can lead to these declines in energy. And when that energy begins to drop, what happens is this is actually a scientific neurological term. It's basically saying that the huge network of 100 trillion synapses, is no longer able to be maintained. And so, what does the brain do? I mean, think about it. Any business, if the revenues aren't coming in like they should, the accountants begin to advise the CEO and the other decision makers to begin to cut back. And where do they start cutting back? Luxury items, right? The private jet maybe is the first to go. No more first class, right? Everybody supplies business or economy, right? Whew. And eventually they have to shut down on certain things. That's the same thing. And I'm trying to cut down what would be a weekend workshop down to about a few minutes. So bear with me, folks. And I hope you can ask questions about if you're not clear about anything. So what happens is that the brain, like the CEO that it is, it begins to shut down. It begins to withdraw. This network that you're seeing, like I said, has 100 trillion synapses. The brain, over 60 to 80% of all the energy that the brain generates to maintain its functions goes towards maintaining this 100 trillion synaptic network. And so it is very, very expensive to maintain this network energy-wise. So what the brain begins to do is that it begins to pull back from these synapses. And if you understand anything about the brain has to have synapse. It has to make new synapses and has to shut down old synapses. It's constantly developing new synapses and old synapses to function. Once the energy is not enough, it no longer is able to maintain the synaptic network. That's why you have things like memory lapses, glitches. I'm not going to mention some other things that old men say, senior moments, wires crossing, some interesting things. And I'm looking at this one, difficulty following a conversation, especially in a group setting. There's a well-known psychiatrist. She developed dementia, and the first sign she noticed was that when she was at lunch or dinner with her friends, it was hard for her to keep up with what they were saying. She thought she had hearing problems. So she has her hearing tested, 100%, not a problem with hearing. Found out that she had early onset dementia. Now, in her case, she did not take it as her fate that she was going to die with the disease. She decided to aggressively look for answers. She found out there were doctors like her who were treating dementia, and she found a way to reverse her own dementia. And now that is her focus now, is on educating and treating people with dementia. But I just bring that up just to point out this problem right here. Let's see, how much time do I have? 10 minutes. Okay. Obviously, asking the same question over and over again. Sometimes it's not that they forgot your answer. It could be that they forgot your question in the first place. It could be that they forgot they asked the question in the first place, or that they did not understand your answer. So it's not just they're forgetting your answer, or they just They just weren't paying attention. And this, by the way, is one of the very, very first signs that a person is going to develop dementia. Obviously, especially a man, if you point out that he's not paying attention or he may be having the first signs of dementia, he'll be very upset. Well, she might be very upset too if it's a woman, because everybody has difficulty paying attention. But I'm saying this because the sooner you catch dementia, the better. The easier it is to treat, and that goes with everything else, including cancer. But one of the first signs, if your loved one is not, he's losing focus or she's losing focus, they're not remembering they're not paying attention. It may just be that they might be having the first signs of dementia. All right, so back to this picture. It all starts with cellular damage. Actually, it doesn't start with cellular damage. It starts with things like attacks, because cellular damage doesn't come out of the blue. It comes with, I call them insults, attacks, things that affect the brain. Now, those attacks may or may not cause damage, but over time, and this is why people say dementia can happen, like it begins to happen 20, 30 years when you least expect it. The most common time that we really begin to see that the damage really begins to take hold is in midlife, early 40s, late 30s. That's when it's kind of like that's when the natural forces, the defenses that the person enjoys as a young person, they begin to wane, and then the attacks begin to multiply, whether it's hypertension, obesity, diabetes, toxins in the air, whatever it is. It just seems like the defenses are not what they used to be. So I wanted to bring this all together so you can just kind of have an idea. This, believe it or not, I know you've probably been told something else. The research has changed significantly. The challenge is that research changes, but it takes sometimes up to 20 years from what is seen in research to be actually practiced in clinical, to be evident in clinical practice. And so we are still, in my opinion, and sadly to be said, in my opinion, we are still using archaic rules to treat a disease that by and large can be treated. And so let's see what happens. So here we mentioned the dementia's dirty dozen. You have, we saw the eggs and all that. Like I said, it's a combination, a collaboration of the different conditions that cause damage. The damage happens. Then the body or the brain, they try to react. They try to fix the damage. So there's inflammation and other things. They try to fix again by recovering, by healing, by repairing. Many times that works, other times it fails to do that, especially if the attacks and the insults are overwhelming. And so damage continues and it becomes a vicious cycle. Now, we spoke about energy levels. At a certain point, when the brain is only able to make about 50%, let me go back to it, about 50% of the energy the brain needs to function, we have what is known as mild cognitive impairment. That's the step before dementia. Now, with mild cognitive impairment, it's evident that there are problems with the memory and things, but the individual is still able to live independently to some degree. Now, if the condition continues to 40% or below, so the brain is not able to generate enough energy to maintain, to reach 40% of the brain energy levels that it requires, that is when you have full-blown dementia and the person becomes unable to take care of themselves. That is when dementia actually happens. So so our approach, and we've been doing this now for over 10 years, and we've seen quite a lot of success and improvements there. Our approach is threefold. One is to address what's causing the damage, the root cause, right? So whether it's diabetes, stress, hormonal, this is an issue with women specifically, when estrogen levels or progesterone levels drop significantly at menopause. That's one. Number two is to address or repair the damage. And the brain can do this if it's given the right tools, the right resources. And that's what we try and do. We find those resources, and a lot of them are nutrients or high dose nutrients. And number three is to restore brain energy levels. We're now finding out that simple things can help improve the brain's energy levels. And I'm happy to discuss that later. And we have this is another picture that we use. We did not think much about energy levels when we're treating kids with severe brain damage, everything from cerebral palsy to seizure disorders and all that, because kids generally have enough energy. That is not their problem. With adults, especially in your 70s and above, that is a huge problem. If we cannot fix, and I feel this is where a lot of research should be focused on, finding ways to improve energy levels in the brain. Because if you cannot do that, everything else is not going to work. There's nothing else that's going to work. And this, I believe, is where we're failing. We are not focusing on the energy levels required to restore brain function. So a couple of stories, so I can wrap this up. There's a patient I have patients around the world. So they find out about what we're doing and then they reach out. So this individual, he has a nurse. He lived in London, so he has a white nurse. He's from my country. We speak a specific language called Yoruba, and she would come in during the day, and she's watching TV. He would come in and he would speak Yoruba to her. His wife would come in, who is also Nigerian. He would speak English to her. Obviously, the white nurse doesn't understand what he's saying, and of course, he does not speak English to his wife. And then he'll be watching TV, and then he's reacting to the TV as if he's part of the discussion. He's arguing with the people. So you can imagine that. That's kind of weird, right? And totally unaware of what's going on. Obviously, he needed help going to the bathroom and all that. So we sent some things over and showed them how to use them. And I was shocked too. Within a week, he was speaking English to his white nurse, Yoruba to his wife, and he paid attention to TV without reacting to what was going on. Another story real quick. A lady, she was in her 70s. They sent me her brain scans. Her brain scans showed significant cerebral atrophy. So, I mean, that's a death sentence right there. There's nothing you can do about it, right? We've been taught that. We put some things together. We shipped them to Nigeria, and a few months later, well, not a few months, a few weeks later, really, he sent me a video of his mom getting up in the middle of the night and going to the restroom. Now, she had always been on Pampers, on pads, because obviously she then didn't have any control of that. The point is not that we're doing something special. The point is that the brain still has a significant amount of reserves, and it can do a significantly more than what we have been trained to expect it to do. We are now beginning to find out that the brain can do so much more. And if it is given the right resources, if it's given the right tools, it's just a question of finding out the best sources of those resources. Most of it has to do with nutrients. I'll have to be frank with you, because the brain needs nutrients to make energy. The brain needs nutrients to repair itself. Once it gets those nutrients, you would be amazed at what it can do. All right, my time is almost gone. I'm going to circle back to the two mics. So I gave you the two mics were, I forgot to mention this, the two white men who are mics. Okay, now the scenario changes when you begin to replace Mike A with maybe somebody who is, well, he's military, so obviously we've covered that. But if it's a black woman, the risks increased significantly. But a black person, if it were a black man, the risks will be even greater for different reasons that we can discuss at another time. Same thing if it were a woman, whether white or black or Asian, whatever. Women have twice the risk of dementia as men do, and they tend not to respond to the dementia drugs that we currently have. They do not respond as well as men do. And yes, to some degree, those dementia drugs help. But what we've seen is that they only help for a little while, 6 months to a year at most. They tend not to last. Again, they work better for men than they do for women. So a lot needs to be changed in how we approach this whole dementia issue. A few notes about blacks. Obviously, you probably don't know this, but we have much higher rates of hypertension and diabetes, cardiovascular diseases. We have to address these things while we're thinking about taking care of our patients. So if you have a loved one who falls into any of these categories or any category at all, it's always important to address underlying factors as well. You never know; it can make a huge difference. I've mentioned some of these. I think I'm just going to skip this because I think our time is almost gone. Bottom line is that medications have their place, especially when it comes to mental health and brain health problems like dementia. But once the brain begins to fail, you cannot, and I think this is really obvious now, you can medicate a brain back to vibrant health. You can only, in fact, you must look at feeding it, nourishing it, the way you cannot medicate a starving child in Africa back to health. You've got to feed that child with nutrients. It's pretty much the same thing. So we have to go from this depleted brain energy to this when brain energy is replete. So I'm going to end that here. Thank you very much for your time. That's my information over there. And yes, by the way, we do take consultations. I'm not, I'm going to just say it out here that I am not licensed practice in the US. So I am more or less a health coach. But what I do, like I said, I treat patients around the world. We have waivers we sign and we can consult with you and kind of like advise you on what you do from a health coach perspective. I am a fully fledged doctor. I am still very much engaged in private practice in Nigeria, and I've won a lot of awards for that. But in the interest of full disclosure, we have to let you know all these things. So with that, Andrea, thank you so much for making this happen.
Yeah, thank you. And we actually had a question come in. So the question is, how do you know if someone needs to be seen for dementia? And how do you test or know someone has early stage dementia to know they need to see someone early enough?
Great question. So depending, I think, and Andrea, I'll let you take that too. But one of the things that we see is when you begin to notice a change, it's not just memory loss or not just problems finding their way home. That's usually a more advanced situation. When you begin to see change in mood, change in behavior, or this lack of interest in certain things that they used to enjoy doing before, um, it may not be depressed. It may not be just depression, or that, like we mentioned earlier, one of the first signs of dementia is inattention. That inability to pay attention means that the brain's energy levels are not. It takes a lot of energy, by the way, to focus and concentrate and pay attention on one thing. So once the energy levels are not adequate, it may not the individual may not be able to do that. So those are the signs. Obviously, like we said, memory issues and other issues can be better, can be larger signs, clearer signs. But those are some of the signs that one looks for. And there are lots of tests that can be done. Everything from the clock test to there are certain standardized tests that psychologists and Andrea, you probably know about some of those tests as well.
Yeah. So, and that's a question I get often from families is how do I know what to do? And so my first thing is whenever you notice a change, if it's for yourself or for a loved one, the first thing is really to have a comprehensive evaluation done, right? Because what if you have low vitamin B levels, for example,
Mm-hmm.
right? And that might be causing some issues. So really having that evaluation done, lab studies done, to really make sure that it's nothing else like a low vitamin B, or hypothyroidism or a problem with sugar. But as far as the cognitive assessments, I see different providers do different assessments. Some do the mini cog, like you said, the clock test and, recalling those three words. Other ones do much longer cognitive assessments. Johns Hopkins Memory Care Clinic, they're not accepting any new patients, but they do like a 4-hour evaluation on people, which can be overwhelming. But I think really, just looking at the full picture is so important. And if you are going to, for yourself or for your loved one, talk to somebody about these symptoms, I always tell patients to make sure that you take concrete information, right? You want to know, when did the symptoms start? What are the symptoms? Is there any pattern? How frequent is it happening? Because the more information you provide, the better the treatment plan can be.
Absolutely.
Yeah.
That's
Okay.
a great question.
Let me see if any other questions came in. Did anybody
Are you
else on the call?
Yeah,
Go
I did.
ahead, Mary. Hi.
Hi, Dr. David, can you tell us what nutrients you focus on? Are you going to leave us in total limbo about that?
Not intentional at all, but so there's some basic things that I focus, that I recommend, like vitamin D3. I don't know if you're familiar with the Alzheimer's Association study that says that.
I'm a neuroscientist and a licensed nutritionist. So.
Oh, are you really? Okay.
Yeah.
Okay, great. Are you familiar with Stuart?
Sure.
Okay. So vitamin D3 is very important. Vitamin B12. So there are 7 I always emphasize to prevent dementia. 4 of them are vitamins, 3 of them are minerals. The minerals are zinc, magnesium, and potassium. Potassium is severely underestimated. The 4 are vitamin B complex, especially B1 and B12 and maybe B9. The vitamin C, very important, vitamin D3, and I add vitamin K2. It's to some degree it's helpful for the brain, but more importantly, it's a stopgap for vitamin D3 to prevent hyper vitamin D3 in the blood. On top of that, there's a wide variety of things, including high dose omega-3s. Melatonin is becoming a rising star in the whole brain health field. And of course, creatine is becoming a rising star because it directly relates to brain energy levels. Now, we do have a whole bunch of other nutraceuticals that can help with improving hormonal function, increasing estrogen levels in the brain. And as you know, the brain, especially with women, estrogen protects. It's one of the greatest protectors of the brain. So it's hard for me to just say which ones. It all depends on the case, and that's why we deal with each case individually. If that answers your question.
Yeah, thanks.
Yes, ma'am.
Does anybody else on the call have any questions? If you do, you can just unmute yourself and just feel free to ask, since we're having a technical problem with the chat.
Yeah, I wonder what's going on there.
I don't know.
I see some caregivers on the call here. Does anybody want to? Emma, come on. Emma needs to say something. And I see Emma Lapp is on the call. And anything you want to add to it? And Elizabeth, Betsy is on the call too. Does anybody want to add to this?
Yeah, I think you've done a wonderful job. I'm sorry, I'm driving my children in the dark, so I'm doing the best I can. But thank you so much to both of you. I wanted to cry when you first started talking, because everything you were saying, even though my grandmother's been gone for years and years now, like, it's so validating to hear someone tell you, like, it's in the brain, it's not you. Like when you were talking about the paranoia and the poisoning and all of that, it's so upsetting as a care provider to go through that. So to hear a professional, even all these years later, when I'm in home care as a profession, to hear somebody tell you that it's in the brain and now there are things you can do about that is wonderful. So thank you so much to both of you. It's been a wonderful presentation. I appreciate you both.
Oh, thank you for that. Yeah, we're glad that you're here.
Yeah, I think both presentations were really well done. Thank you.
Yeah, thank
Thank
you.
you, Mary.
We
Thank you,
do
Emma.
have one other question that came in through email, just asking, what should you do if you see the provider with memory concerns and they don't seem to take it seriously?
Hmm. Yeah, there's only so much you can do. I mean, yeah, you got to keep looking. I think it's unfortunate, and it's not just in dementia. Even in menopause. I understand that only 1 in 5 OBGYNs can help somebody struggling with the symptoms of menopause. So think about that:
Wow.
hot flashes, night sweats, mood swings. I mean, these things could wreck a marriage, right? And only 1 in 5 only 1 in 5 OBGYNs actually know what to do to help effectively help this individual navigate the treacherous waters of perimenopause.
Yeah. Wow,
um,
that's alarming statistic.
Especially when you realize how important that is to brain health. So the same thing with dementia. Unfortunately, we've been trained as neurologists have just been trained that if somebody comes and there's a diagnosis of dementia, really, that's a death sentence. There's nothing that can be done. We will just do what the book has told us to do, which is administer these pills. Like you said, have them come back in 2 months, 3 months, 6 months, and just monitor their decline. Unfortunately, and
Mhm.
I don't want to sound insensitive, but that's really what it comes down to. They will not tell you this, and doctors should offer hope, and many of them do. But the truth is, they know. Any doctor treating dementia, doctor, nurse practitioner, they know that there's nothing that can be done in their field to truly reverse or even turn it around or even stop it from declining. All right.
Mhm.
Even the drugs that are out now, the most recent drugs that are out now, there's a lot of talk about, oh, it's great, it's slowing things down, but very little is said about the side effects. And we're talking about almost as much as 30% um, of cases they see brain swellings and or bleeding in the brain as a result of using these medications. These are not pills that you can give in an outpatient basis. These individuals have to be admitted to the hospital and given these treatments IV, and they have to be closely monitored, and they have to have regular MRI scans. These are not things that you can just do whenever you feel like doing them.
Mhm.
So I think a lot still needs to be done in the field of treating dementia, because right now I just don't see this as being scalable. Certainly, it's not going to work in countries like Africa, and we're seeing huge numbers of dementia now. It's picking up significantly, especially since the pandemic. So in answer to the individual who asked the question, I would say you got to keep looking and stay tuned on calls or webinars like this.
Mhm.
The answers
Yeah.
are out there.
Yep. Okay, thank you. Anybody else have any questions before we end for the evening?
Actually, I do have one question, if that's okay.
Sure.
Doctor, do you feel that there's a kind of a point of no return, as far as like once you've gotten to a certain point or been so long with dementia, do you feel that these techniques could still be beneficial, or do you feel like there's at some point just it's too late?
Yeah, there definitely is a point of no return where there's pretty much nothing the individual can that can be done. Um, but in my experience, we've seen again. I've come from Africa, so we cases tend to come to us when they're very very late. We've seen maybe not 100% recovery. We've seen significant improvements or just stopping
Hmm.
and to getting things back. My philosophy is that there's not a situation in which you cannot do something as long as the patient is able to eat and able to swallow. That's really what it comes down to, because our our therapy relies on an intact digestive system.
Thank you.
You bet.
Anybody else? Okay, well, I want to thank everybody for joining. I'm happy that you all could be here, and you have both of our contact information, so don't hesitate to reach out if you do have questions.
Thank you very much. This was very helpful.
Okay,
Yeah,
Thank
great.
you very much. Appreciate it.
yep, take care.
Everyone
Thank
take
you.
care.
Thank you. Have a good night.
Bye-bye.
Bye.
Bye. I'll call you, Andrea.
Okay, that sounds good.